We are live.
We're live.
Okay.
This is Senate Appropriations, February 20th. Senator Norris is not late.
He's right on time.
Well, that is the pro tem's office, and she's here, so.
So we're talking with HS about the FY26 budget. And welcome back to the committee. I'll let you introduce yourselves to the record and go from there.
Thank you for having us back. For the record, I'm Jenny Samuelson, the Secretary from the Agency of Human Services. Chair, if we will go through the broad policy components of the budget. And then I have my colleague here with me as well, Rich Donahue, who can go through the line by line.
Yes, and for the record, Rich Donahue, CFO of AHS. Good afternoon.
You have the presentation.
So to hit the high levels of the Agency of Human Services fiscal year 26 budget proposal, the Agency of Human Services is requesting a 5.81% increase in the general fund base budget. There's a couple of key themes that will emerge as we go through where that is allocated. One of them is that this is primarily a current services budget. 5.34% of that increase is directed towards current services, primarily at the Medicaid consensus, which is a combination of Medicaid utilization and Medicaid eligibility. In addition to that, it's a movement of one-time side letters that existed for the Department of Corrections, which were intended to address the staffing crisis in corrections, and moves components of that over into the collective bargaining agreement. Beyond that, we have overall about 3,835 positions proposed. That's a slight increase of 0.02% or 6 positions overall from the fiscal year 25 budget. When we go beyond the current services budget that we are proposing, there are a few key initiatives. And this year, those initiatives really focus on filling the gaps that we've identified in our substance use system of care. So it's not significant new services, but really filling in where we know that our substance use programs are falling short across the state, particularly with the evolution from it primarily being an opioid epidemic to being an epidemic that includes significant polysubstance use with stimulus. So in addition to the continuum of care proposal that you'll see in our substance use program, we're also continuing to expand the pilot for pretrial supervision. So both of these you'll see in the omnibus proposal around public safety, the substance use component and the pretrial supervision. And from an Agency of Human Services perspective, these dovetail closely with each other. And I'll go into more detail in a little bit. Once we get beyond the current services and beyond the initiatives, there's very little that fits in here, but I'll go through in more detail. For our one-time asks, it's primarily focused on moving past priority initiatives from one-time into the base. So you're not seeing new things here. But in this case, it's the shelter expansion that we did as last year as moving that from one-time to base, and now continuing to have one-time funding in our shelter expansion. In addition to that, for the base, you will see alternatives to emergency departments, which are otherwise known as mental health urgent care. So beyond the base initiatives, you're seeing here us moving those items from last year's one time into this year's base. So very little new.
Is that the shelter expansion? Was that the 10 million for emergency shelters?
So last year with the 10 million for emergency shelters, what you saw us do is stand up emergency shelters that were intended to be ongoing from community-based providers. So that's exactly what this does. This moves though it was the one-time funding for those into the base. So again, nothing new, but really taking our past initiatives that were one-time, moving them over into the
That
base.
includes the family shelters.
So the two family shelters, the one in Waterbury and the one in Williston, were stood up by the state. And so it does not include that. What you'll see is a
Well,
commitment
this is
to,
for like the providers, the money going to providers for emergency or temporary shelters.
yeah, so this includes expansion of shelters across the state, St. Albans, for example, in collaboration with Spectrum. It includes funding for a shelter that folks are continuing to work to set up in the Rutland area. DCF can go into more detail about where these shelters are, but they are statewide.
But they're permanent or they're part of
They're
the temporary? Okay.
They are permanent, and they've been moved from the one-time permanently into the base to reflect the continued need for expanding shelters.
Is that the HOP program or?
Mhm.
Yes.
That is,
Yes,
okay.
the Housing Opportunity Program. So in addition to that, in one time, we're continuing to have startup funds for any of the startup funds for the substance use treatment, but we also are continuing to add one-time funds for shelters. For example, what we've done this year to have the specialized shelters put in place for families, which we want to be able to continue to meet the needs of very vulnerable populations, families, and those who are medically vulnerable. So you'll see that in shelters for next year. And then this past year, as we move between the all-payer model and potentially a new model with our federal government, we've seen the loss of funds for primary care, for blueprint funds, and for SASH. And so you'll see those funded as one-time funds in the budget. So again, the key themes here is it represents primarily a current services budget with the majority of the pressures and things that are things that are outside of our control. They're requirements from the feds or the state, filling in gaps in our substance use system, and then maintaining key elements of past initiatives that we've identified are high priority and have had and demonstrated results.
Where are you doing PCB testing?
And PCB testing is also here, and we'll go into more detail
Where
about
is
how.
that?
That's in the,
That's in the BDH budget. BDH is providing professional services to ANR for that related test.
We just talked about DC's PCB testing and their money they need. So it's the support the Department of Health is giving DC for the program.
Correct.
Staff time, basically.
And lab.
and lab, this lab testing piece.
Okay.
Okay.
Do you want to take this one?
Sure.
So this is just a snapshot and a pie chart of the general fund distribution in the Agency of Human Services. You can see the three largest slices of the pie are matching funds for global commitment, because for every $1 of global commitment appropriated in state government, there's a state-funded match dollar that's required in order to pull down the federal medical assistance percentage or federal funding component. And then DOC and DCF. And there's a small amount of general fund of $16.1 million for operating costs and personal services in the Secretary's office. The Secretary's office also has the GC mixing bowl appropriation, that you've probably heard that terminology before, and that's where the state and federal funds are used to match in order to appropriate global commitment dollars.
So I touched on this before. The agency has a slight increase in the number of positions. It's a total of 6 positions across the agency, bringing us to 3,835 permanent positions. In other spaces, you might have seen us with a number of a little over 4,000. That includes temporary positions and limited service. So to go into a little bit more detail about what our program budget, when we look at the current services pressure, or that 5.34%, as I noted, it falls into several buckets, which are requirements primarily from the federal government or state legislation. The first is the Medicaid consensus, and that includes a combination of caseload and utilization, and is a total of $21.4 million of general fund increase. In Vermont, there's also a statutory nursing home rate rebase and inflationary increase that happens on a regular basis. This represents $6.3 million of general fund to meet that pressure. We've also seen in terms of utilization, so not rates, the nursing home bed day utilization has returned to pre-pandemic levels. What we saw is during the pandemic, we had a lot of beds offline in our skilled nursing homes. The challenge with that is we were seeing individuals instead continue to remain in board in hospitals. So this increase gets us back to our pre-pandemic level of access for skilled nursing beds, and that's estimated at 10.1 million. And what you'll see is that's a carry forward from BAA into this year. So we've talked about that before in BAA. There's also adequate funding or funding that's been moved, as I mentioned before, from side letters that were for corrections. Previously, during pandemic times, we had over a 30% vacancy rate in corrections, 24/7 mandatory facilities. Folks can understand the challenge there. They have moved the successful components of that side letter into the collective bargaining agreement with the state for $17.9 million in general fund. And with those, what we've seen is we've reduced the overall vacancy rate. It dropped down to around 14%. It's now hovering around 17.9%. So it's cut that vacancy rate in half.
Which is high for somebody else, but low for corrections.
It's high for someone else and it's low for corrections. That's correct. And we're continuing to work on that, but with other things that are not money related. So our current services savings, those are all the pressures that cause increase. It's worth noting that there were places that we saw shifts and changes where there were potential decreases in funding in the budget. One of them is the federal medical assistance rate change, or FMAP, and we saw that went favorably towards us this year. I do have concerns about what that will look like in the coming years. And so I just want to preface that what we are seeing at the federal level indicates that there may be some challenges in some of these areas going forward. Including also in the child and this new adult, these are both Medicaid. And so we're seeing decreases based on the FMAP funding there. Is there anything you want to add?
Because of the increased caseload utilization for childless new adults, we currently receive a 90% enhanced FMAP from federal government for that population. So because there's an increase in those services, we get more federal funds, and so there's $3.1 million of general fund savings here projected for fiscal year 26.
Yes. There's also the Child Care Financial Assistance Program caseload. We've seen a lower caseload than was originally projected. This is a new program or new changes to that program. The original, we were now syncing up what actual utilization is with projected utilization for a net down of $3.5 million. There's the Reach Up caseload adjustment, the Family Services Division caseload adjustment. Both, again, these are caseload adjustments, taking and making it actuals versus projections. And then we're seeing a DOC net vacancy savings of $6.1 million.
And on the top part, the general fund gross, that's the difference is the global commitment dollars.
Yes.
Yes.
Exactly. So that's reflecting the match rate that we have with our federal government, with the federal government.
Do you know why it's called global commitment? Could we have used a different term?
The global commitment moniker goes back to the original 1115 waiver, approximately 15 years ago. I don't have more information than that, other than I believe that the original construct was a global budget that we had to stay within. And at that time, when we were able to bring in actual costs below those projected ceilings, we were able to retain those savings. And that's what helped contribute the funds that are currently in Human Services Caseload Reserve. Yeah.
So that was the commitment to the state. If you stayed under the global budget, your commitment of keeping the funds.
And even now, what we've been able to do with that global commitment is it allows us to invest in things using our 1115 waiver that other states are not able to invest in. So I think that's one of the things that's going to be really important over the next few months is to understand that the Medicaid program that we have here in Vermont goes beyond in many areas what is the minimum requirement of the federal Medicaid program, and we've been able to do that by leveraging our 1115 waiver or the global commitment. We stay below the cap. We can make investments in services that are not mandated Medicaid services.
There are some states that also have global commitment. We're not the only one.
There are some.
There are other 1115 waivers. I don't know if anyone else refers to their waiver as the global commitment waiver, but there are other 1115
I also
waivers.
think that the way that our 1115 waiver is constructed is with the global commitment construct that we were just discussing is unique to Vermont. It is not the way that the majority of the 1115 waivers are currently structured.
And originally, when we were able to retain savings, that's not how it works now. That was as of a point in time. But we are able to use Medicaid dollars in flexible ways that otherwise we wouldn't be able to with just a straightforward state plan.
Right.
Yeah.
Okay.
As long as we stick below a target.
Total spending.
Yeah. So this is where I get excited, to be honest. In the initiatives this year, we have identified that there are significant gaps in our substance use system of care, several of which we are addressing in budget investments. We are seeing that enhanced treatment in our substance use disorders services. Sorry, did you have a question? No, I'm good. Okay, so what we know is in our substance use treatment disorders residential treatment system, that it did not include all of the levels of care, which meant that if you were withdrawing or relapsing or otherwise coming into the system, if you didn't meet the current criteria of a residential program, it was very difficult for you to get in. So what we've done here and what we're doing here is setting the standard of care so that residential treatment programs serve the full breadth of residential treatment. They also are integrating services into their programs that are services to help individuals navigate from residential treatment back to their next step, whether that is recovery housing or back home to their communities. It's a critical transition, and we have, listening to providers and families and many others, these are critical pieces to being able to get into care when you need to get into care and to successfully being able to transition care. One of the other elements here that we've committed to is looking at the payment methodology. We've heard a lot of providers talking about how the payment methodology does not incent the length of treatment that we would want and see. So in addition to looking at the financial investments here, we will also be looking at the overall payment methodology for residential treatment.
Could you, I'm looking at the 15-bed recovery campus, and it doesn't, there's $1.5 million. How far does that take us? Does that cover it?
Yes, so there are two components here. You'll see that there's a $500,000 one-time startup cost. And this is out for RFP, but the estimates based on some initial work that we did with providers is that 1.5 million gets us a recovery campus. And for the record, the recovery campus really takes and marries together recovery housing with essential treatment services and life skill services all in one space. So as individuals are transitioning out of residential treatment, we know many can go home or many can be successful in recovery housing, but there's a cohort of individuals who have a level of complexity that having to continue to be served as an intensive outpatient and making that leap rather than having it right on site has been very challenging, particularly in populations like those who are involved in our judicial system, those who are experiencing homelessness. They need more support. And so we know that we need recovery housing in the state. This is our addition to into recovery housing is adding 15 beds of recovery housing, but those beds offering more intensive services than the peer-based recovery programs that we see in the rest of the state.
And this facility, the campus, is in play already, or is this a whole new initiative from ground up?
So we believe that one of our current providers is likely to add this level of service. And so it's likely that we already have a treatment provider who is working towards developing this, and this helps to support that. So in addition to that, there's, as I mentioned, there's the $500,000 to support the startup costs for that initiative. And we recognize that there are 70% of the population in correction is currently receiving medication-assisted treatment for substance use disorder. We have, looking at the programs, we know that medication-assisted treatment is not enough. And so for many of the clients that we have, it would benefit them to not only receive medication, which provides stabilization and prevents withdrawal, but actually to get full residential level of treatment. And that's not happening in our correctional facilities. And so our goal here is to evaluate what it would take to take one of our correctional facilities and to make one of the correctional facilities a residential treatment provider for those who are incarcerated. We believe that will assist them. It's voluntary. Treatment and corrections is whether we're talking about medication or currently the level of counseling that people are able to receive. It's voluntary, but we recognize with 70% of the population experiencing substance use disorder that there would be significant benefit of being able to provide residential treatment for those who are currently incarcerated. We believe that will also assist them in transitioning more successfully back to community. I think I saw a question on the side.
Is it the entire facility will be converted, or they will take a part of the facility?
It will be the majority of the facility, so that it still serves the community. That's one of the things that they need to determine. There may be a small portion of the beds that are continued to use for individuals who are coming in for incarceration from the local community.
Okay.
But this, in addition to studying what it looks like, this also puts in what we believe will be the cost to begin the implementation for hopefully the last quarter of the year.
So you could, with this 300,000, the study and something from
The study and the start. Now, without the study, I want to be clear, we're not sure what the full costs actually are going to be, but this is based on a rough estimate of what we think the cost of using one of our current providers who helps corrections set up systems of care, to use one of those current contractors to help them design what it would look like to convert one of the facilities, likely the facility in St. Johnsbury.
Yes, Senator Watson, and then Senator Lyons.
I guess I have a question / comment really about the shelters, but it is related to recovery. And I just want to recognize that I don't know if this is the right place to raise this, but I just want to note that for communities that have a lot of shelters, there is also an increased demand on police, and as I understand it, there's no I don't know if we were going to support municipal police departments that have shelters in their communities, or some of the hotel.
I was going to say, are you speaking of shelters?
I think it's the hotel. It's not really the shelters. Well, actually, I'm not sure I can say that it is not, but
the public safety data
exactly
supports what you say, that where we have hotels,
right,
we have an increase in public safety related issues.
Yes, and so I don't know if we would go down the route of trying to support municipalities that have hotels in their, in their areas, but I don't know where that would live if we did. Do you know what I mean? Like, would support for municipalities live in the AHS budget, or would it live in the?
Do you mean support for the law enforcement? Company?
Right, or maybe it would live in the public safety budget. I just want to raise it as an issue, that it's something that I'm thinking about and concerned
Probably be
about.
part of the GA budget. And there was some agreements between some police and some hotels, but I think those were just, the state wasn't involved. They were just.
There at times we've funded security. The data does demonstrate that where we see hotels, we see an increase in drug and human trafficking and other related issues. The treatment providers that I was speaking with this morning really spoke to how congregating individuals in an area where there aren't services really has allowed, and I would, like Judge Reese or some of the other providers can speak to this, really has allowed individuals to be taken advantage of. So drug traffickers often come in, they use the hotel rooms that we currently have to set up shop, and it's an environment that's really challenging.
Yeah, I just want to flag it, and we don't need to, solve that right now.
And having security, like before it wasn't law enforcement, it was having some on-site security. Some hotels have set up some on-site security as well. That hasn't been the solution. It's worked so far. I think for many of the folks who are interested in going into recovery housing is a good investment in the long term. We've got many of our individuals who come out of our programs who, like out of corrections, and it's really difficult to stay substance free in some of those environments.
Yeah.
Senator Lyon, you done?
Well, it just as the conversations that I've been having with folks in police force, they're all for supporting recovery and more services.
Recovery housing is a great option.
Thank you. So I know that we're going to be talking about this soon, and we do have a bill in health and welfare on recovery residents and how we can improve the continuum of care for folks who have that chronic illness. So it will be important to look at what the language is around a 15-bed recovery campus, knowing that when we took up the issue around Jenna's promise and the 2 grants of $500,000 each to sustain the work that they're doing. If we start building these things before we have a framework a policy framework, it could become exceedingly expensive. So I'll just say that for now, because I know we're going to talk. I know that our committee will be working on this, and we will have policy recommendations. I don't know how the budget is going to be handled in the House around this. I know we have a report coming in the fall regarding what we have across the state and how to integrate whatever we have. And I know that there was a report that just came out that our committee is looking at. So, and so I'll let you comment on my comments, but then moving to the correctional facility, it will be interesting to know how this all sugars off, given the need for transitional housing and that continuum from corrections into the community. So I'll end there, but there's a lot right there.
Yeah, I think we'll be bringing this up in the House, in the Senate Health and Welfare Committee as well.
Yeah. But
I think that for the recovery campus or recovery housing component, I believe that there already is a framework. And as I mentioned, based on the previous question, Jenna's Promise is an example for women of a recovery campus.
Yeah.
I estimate that we will see a provider like Jenna's Promise or like one of our residential treatment providers, which is the example that we see in New Hampshire, where they add recovery housing on campus. And so there's an RFP already out. So there's somewhat of a framework built already for this. And this really is a budgetary ask to be able to expand into this program.
So going to the framework and the guidelines and the principles and the criteria that are or are not in place. I know we've relied very heavily on the significant work that Genesis Promise is doing, and they've got a unique situation. I'm thinking it might be important to learn lessons from what they have and then put those lessons into words and into, I don't know what the RFP says. So, this will be a good conversation there. I'm actually looking forward to it.
Yes, I think it will be a good conversation, and we've worked heavily with the provider community to identify this as a gap and to move it forward.
Yeah.
Okay. There are no other questions on the substance use and continuing care. And again, the continuum is broader, but these are the budget implications. Okay. Other initiatives that we have really reflect us moving past initiatives from one-time to base. For example, the alternatives for emergency departments for mental health, otherwise known as mental health urgent care, were funded with one-time funds through the HCBS, the Home and Community-Based Services FMAP. What we have seen is that the combination of 988, mobile crisis, and alternatives to emergency departments have really resulted in a decline in individuals in emergency departments and wait times. So we believe that this should be moved, that we should put this from one-time funding into our base. In addition to that, $3.3 million will assist in moving the shelters that we expanded this year, as we talked about previously, into the base so that those can continue. We recognize that across the state, we continue to need to advance the shelters and the number of shelter beds, specifically to address some of the issues that we've already spoken about. That when we put shelters in place, shelters have an opportunity to provide services and housing in one place to support the clients that we serve. We also are looking to scale current programs. So pretrial supervision, and this does connect with the substance use proposals. Pretrial supervision allows those who are detained but not yet tried to receive probation and parole-like services. It's the best analogy that I can identify, but probation and parole-like services. This assists individuals in complying and having accountability to what the courts have mandated are their requirements for release while they are into the community before their trial. This couples with really well to help support individuals who may, for example, have substance use conditions of their release. It allows us to try to intervene before we have an issue where there's recidivism and to support them in treatment. And so we really believe that continuing to expand that program not only assists in the broader public safety, but also will assist in our substance use programs.
And are those grants to providers? Is that what?
This is actually the Department of Corrections implementing pretrial supervision. So it's very much like probation and parole. It's in one county, and this expands it to a second county. Did I see a question?
You just answered it.
Perfect.
And the
Thank you.
overall GA budget is flat?
The overall GA budget is proposed to be flat compared to last year.
Yeah, there are a few operational adjustments that DCF can go over in detail, but yes, for motels and hotels, in terms of that service line, that remains relatively unchanged.
It's like 38, no?
The base budget is $7.5 million for motels and hotels, and then the remainder is funded with one-time funding.
For a total of
And then the governor's recommended budget proposes $30 million in fiscal year 26 and $7.5 million in the base budget to continue the current law
Right.
program.
Okay.
Yeah.
Thank you.
Yeah, and our
They can
goal,
get
our
the
goal
rules
is to, our goal when we built the budget was to fund fund the current law. And so that's what's in the budget,
Okay.
is to align with that.
Senator Brandon or Norris, maybe you have.
Go ahead, Bob.
So I'm fully aware, sitting on judiciary, this was the late Senator Sears' project. As far as it's concerned here with DOC, as far as the monitoring system.
The pretrial supervision.
Yes. This just started, I assume? It's been a couple months in the works now, or?
DOC can provide you more detail, but it is started in this fiscal year.
But it's still just for one county?
It's just for one county. And so our goal is to have a scale plan over time with this expanded to an additional county.
Okay, thank
The
you.
preliminary results are successful.
Preliminary results have been successful.
Senator Brandon?
I'll ask my question offline. I think it might be more of a question for DCF.
Okay.
Okay. So in the one-time funds, we had been negotiating with the federal government to move from the all-payer model to potentially another model. What you see is $10.8 million or $4.5 million to continue Medicare's investment in Blueprint community health teams. And just as a reminder, those community health teams support primary care practices in implementing preventive and advanced care, including hub and spoke, and in primary care payments, so a per member per month payment. So this is a combination of the two of those, plus SASH, Supports and Services at Home, is a program that is almost exclusively funded by Medicare. And so this puts in funding to bridge the gap if we were to move into the AHEAD program, to bridge the gap in between those two programs.
And the governor is recommending that we do go to the AHEAD model.
All three signatories signed
Right,
the
oh,
AHEAD
that's
model.
right.
I want to be
Including
cautious,
yourself.
given what's happening at the federal level. We need to make sure that we continue to see executed the current agreement before we come to conclusion. So there's also $2 million for one-time funds for shelter beds. Again, this year we really prioritized shelter beds for vulnerable populations, as you saw, families with children. And we've been working to expand medical respite, which are programs that help to support those who are medically vulnerable. And so we also recognize that the general assistance housing program, as it currently exists, does not fill its fundamental function that it originally filled. The original genesis of the GA program was to prevent life and safety issues. So essentially prevent people from dying from hypothermia in the winter. The program right now is not able to on the coldest nights. It is fully subscribed. And so we've turned more than 600 households who are eligible for the current program away based on the total number of hotel rooms. And so this again, with that $2 million is really focused on shelters that would fill the gap. As you've seen, many municipalities this winter have set up cold weather shelters. We believe that that's an important component. You've also seen the family shelters and medical respite.
Okay. And then I think we already talked about PCDs a little bit. And I know you have a lot of ups and downs too, but we have to end because we have to get ready for a public hearing. So we can either have you back or we'll hear it from all your departments when they come in, unless there's something.
We were going to provide the ups and downs detail for the Secretary's Office's appropriations. Happy to come back at your convenience to run through those appropriations. Otherwise, each department will go through their own appropriations.
And I think Senator Lyons and also Senator Westman are kind of AHS's liaisons, so they can. I think you said at the beginning there wasn't anything big in your office with ups and downs, so.
And we covered the major moving parts for our budget with the global commitment appropriations.
Less than 1% of the budget.
Yeah, only 3,000 employees.
Yes,
But
but for,
no, I'm talking about that, the secretary.
The
Oh, the secretary.
Central
It's
office,
less than
secretary.
1%.
yeah, so, what we were gonna do today was just the secretary's office. I know you'll have the departments in, to walk through their specific budgets. Our goal today was to give you an overarching view of kind of what our thinking was
Yeah, that's right.
across departments. What you'll see here, for example, on the substance use, is a significant amount of collaboration and investments. It's not in one department, but it's structurally across the entire agency, which is one of the advantages of having a comprehensive human services agency.
Yeah, great. Well, I appreciate your time. So we'll reach out if we have any other